Hello, my name is Sam Rodgers-Melnick. I'm a music therapist and an integrative health research and data specialist at University Hospitals Connor Whole Health, and I'll be talking about music therapy for acute and chronic pain. So you might be wondering or have an idea of what you think music therapy is. Some people think it's we go into rooms with singing bowls and do some chants and make patients feel better that way through the vibrations of the musical instruments, but it's not quite that. Some people think that we're just sort of entertainers in the hospital. Again, not quite that either. And some people think that we, present, do an assessment, tell the patient, hey, listen to some Stevie Wonder on an iPod and call me in the morning. But it's not really those things either. Music therapy, the official definition from the American Music Therapy Association, is the clinical and evidence-based use of music interventions, whether that's music-assisted relaxation or active music making like I'm doing with this patient here, to accomplish individualized goals, whether it's stress reduction or pain management, that occurs within a therapeutic relationship by a credentialed professional like myself, an MTBC music therapist board certified, who's completed an approved music therapy program like I did at Duquesne University, followed by my internship at UH. In terms of the evidence base for acute pain, this was a meta-analysis in 2016 of 76 studies with 6,400 patients. And it looked at both music therapy interventions and music medicine, which is where healthcare professionals give individuals iPods or music to listen to. And there were large effects between the intervention and control within both groups, but a larger effect within music therapy compared to music medicine. And then this was a study in palliative care by a former colleague in 2013, a randomized control trial. And we can see clinically meaningful reductions in the music therapy group of about 1.9 units on the numeric rating scale as compared to half a unit in control, for a mean difference between groups of about 1.4 units. More recently, at university hospitals, we've been doing these large observational studies because we have a very large music therapy program, sees over 10,000 patients a year throughout 10 medical centers. And again, we see large reductions, about 2.04 units in a numeric rating scale of pain intensity among hospitalized individuals at community hospitals who had moderate to severe pain. My focus has really been on individuals with sickle cell disease. These are individuals in the United States, primarily identifying as Black or African American, who have excruciating pain because the red blood cells get stuck in the blood vessels. And this was a depiction by a patient who described it like a punching bag, a razor blade in the abdomen, shattered glass in the chest, like her legs were on fire. They experience so many different types of pain: neuropathic pain, bone pain, vaso-occlusive crises pain. And so my research has looked to address the needs of these individuals. And what we're looking to do here is not so much focus on pain intensity, like how much pain you feel right now, but really in chronic pain, how is pain affecting your life day to day? How is it interfering with your life day to day? And I believe if music therapy was working well, let's say we were looking at this scale where time is on the x-axis and the promised pain interference t-score is on the y-axis, where 50 is normal, and if you're below that, you don't have as much pain, and if you're higher, you have much more pain. We're hoping to reduce the degree to which pain interferes with your life day to day over the course of treatment. And in this trial, this musicals trial that we did a few years ago, it was 6 sessions amongst people with sickle cell disease who also had chronic pain. We did an education session. We taught them ways to use music to practice deep breathing and progressive muscle relaxation, and go to a place that felt safe and comfortable for them, and to engage in active music making. We would make these and collaborate on these tracks in real time, and I would record them in my mobile studio and give these to the patients to practice. And over the course of the study, we looked at changes in pain interference and self-efficacy and other quality of life measures as compared to a waitlist control. And in this study, we did see statistical differences between groups, even in this small study: improvements in self-efficacy, reductions in sleep disturbance and pain interference, and improvements in social functioning impact as compared to waitlist control. When we interviewed people, patients talked about how music therapy could transfer them to a different place. It takes my mind off the pain. It puts me in a whole other world. This idea that when music is here, pain is over there. We hear that from a lot of the people that we work with who experience music therapy. And patients also talked about having improved coping skills. They had other things that they could do to cope with pain besides taking medication. This helped them to accomplish more of the things that were important in their life day to day. And so moving forward, we have an emerging evidence base, a lot of music therapy studies on acute pain intensity, one session. We are looking to investigate how music therapy addresses more clinically meaningful outcomes in chronic pain, pain interference, self-efficacy among people with chronic complex pain like sickle cell disease and advanced cancer pain. And so we need to get beyond these single sites and do some multi-site studies of music therapy for chronic pain. Looking at virtual delivery, how can we meet people who are throughout the community and not just coming to an academic medical center? How do we intervene early? People with sickle cell disease can develop chronic pain at an early age in adolescence. How can we screen for that pain early and provide integrative pain management early to prevent pain from being more burdensome later on? How can we combine multiple integrative health and medicine modalities individually and collectively? People with sickle cell disease have neuropathic pain and bone pain and nociceptive pain, and different modalities might affect pain in different ways. So how can we best collaborate there? How do we look at different pain dimensions? There is a cognitive component, a neuropathic component, an emotional component. Each one of those has a different mechanism of action, which then gets to another future area of inquiry. What is happening in gene expression measures and inflammatory markers in the blood and with brain imaging on fMRI? So we look forward to pursuing these at university hospitals moving forward. And these are some of my references if you're interested. I really thank you for tuning into this virtual presentation, and I hope to see you sometime soon.